Welcome, everyone. I'm back here today with Dr. Doug Fraser, who is a pediatric intensivist. And today we're going to talk a little bit about how COVID affects pediatrics, as well as Dr. Fraser's research in something called the cytokine storm. So welcome, Doug, and thanks for joining me.
Thank you. It's a pleasure to be with you.
Doug, how did you get involved in this research?
Well, about 8 weeks ago, when COVID-19 came on, we were really well prepared here in London, Ontario. We have a biobank, which we use for research purposes, where we collect tissues under ethical principles, of course, from patients. And we also have all the infrastructure, so all of the people and the places and the equipment to work with human samples. So when this happened, we were pretty much ready to go. And we quickly talked to our ethics department and our biohazards departments, and we were rolling thereafter.
Now,
so,
were you doing research on ICU patients that were doing poorly before this?
Yeah. So that's been a lot of my career. Is any patient that comes into an intensive care unit, whether it be a child or an adult, we often collect samples from once we get consent from a substitute decision maker. And those samples are kept in the biobank, to which we can then do a number of tests over time on to help us understand diseases and responses to therapy.
And what are you finding with respect to the patients with COVID that do poorly compared to those that recover quickly?
Yeah, so we, whenever a patient comes into the intensive care unit and has symptoms that appear to be like COVID-19, they are immediately enrolled into the study, and we take daily blood and we follow those patients for 1 week with daily blood, and then we take blood every 3 days thereafter until they're discharged or tragically die. And we're following those samples for how the immune response is, how the inflammation in the body is, and how prone they are to clotting within their blood vessels, among other things. And we're really starting to get some very, very intriguing data, which seems to be very specific for COVID-19. In other words, we're comparing to the other infectious causes that we look at that put people in the ICU, whether it be bacterial or other viruses, and the response is extremely unique. It's something we haven't seen before.
And Can you tell us a little bit about what you're finding?
Yeah, so you've probably seen on the news, or you may have heard of a cytokine storm. And what cytokines are, they're released from your immune cells, particularly your white blood cells that are floating around in your blood all the time. And they're signaling molecules that help coordinate your response to a pathogen or to an infectious agent like COVID-19. And if those cytokines, if the response is really exaggerated or if it's prolonged, it not only helps to destroy the pathogen itself, but in fact, it will start to cause damage and injury to the body as an unintended consequence. What we found in the COVID patients is that the cytokines and the enzymes and all these molecules that are involved in this process, they not only go up very rapidly, they go up high, and they are persistently high. And they stay high in those really sick ICU patients that have a very high death rate. So in your typical patient that does not have COVID-19, but another infectious cause, many of those molecules go up, but they will go down shortly thereafter. And one in particular will go up, it'll start the cascades. In other words, it'll let all the horses out of the barn, but it goes up and down very quickly. Whereas what we're seeing is the molecules go up, they go up very, very high, usually 5 to 10 times higher than what we see in other diseases, and then they stay up and they're prolonged. And when we see that, we know the patients are going to have troubles, because part of that process also involves enzymes, and those enzymes can chew up your own tissue, particularly the tissue in your lung.
Now, Doug, can you speculate on why that is, specifically with this disease, that happens as opposed to any other infection?
So purely speculation, but there's something about this coronavirus, which is very novel, and how it activates the immune system. That's one aspect. Mm-hmm. Another aspect is certain individuals may have genetic susceptibilities that we haven't worked out yet. So they're just much more prone to having a bad reaction if they get this virus. And that's probably the population that's winding up in the ICU. Other reasons include advanced age. So we know that if you're older, you don't do quite as well. And then also if there's other comorbidities or other disease processes going on, like diabetes, hypertension, cardiac disease, you're also more susceptible. So it's probably a combination of things, and that we haven't quite worked out yet.
Doug, we're seeing that clearly there's a wide range of responses that patients have to this. The vast majority seem to have it and recover, and many are asymptomatic, and there's a very small percentage that do worse. Do you think that your research could possibly explain why this is?
Yeah, well, I think just by characterizing the immune response and the inflammatory response to which we've done, we now know a lot of the molecules that are involved in that immune response and the cascade, and those that are elevated to very high levels and those that stay elevated. Now that we have that information, we can start to target them directly in clinical trials to see if we bring those particular molecules down, particularly those enzymes which are chewing up the tissue. If we can bring them down without harming the person, then we'll have a particular therapy towards this. And it's also giving us more information that these molecules are the key ones that are involved that are making you sicker.
Are there therapeutics that deal with this?
There are some that are out there already. In today's world, we have the ability in big pharma companies in particular to create molecules at a very rapid pace, which can target these molecules very, very effectively. So in today's world, if we know something about the cytokine, we know something about the structure, and we can determine by the structure what kind of molecules are going to inhibit it and at what sites, and we can design them using a variety of chemical processes and then test how they interact and then test them in people. That can happen very quickly.
Yeah. Now, within the range of therapeutic that's available now, is there anything that works on dampening this immune response?
There are a number of therapies out there, and in fact, we are pursuing those very aggressively right now. They have not worked in sepsis patients or patients with infections that wind up in the ICU previously, but that's likely because the immune response is transient, it comes and goes, and there's a lot of redundancy in the system. So by the time we actually see a patient in the ICU, we get one of these medications in them, it's probably too late. Whereas with COVID-19, what we're seeing is an exaggerated response, it's prolonged. So the actual time window to inhibit these molecules and make a difference in the actual patient is very, very different, and it might work in our advantage. So yes, we're actively pursuing those, and in fact, we have a clinical trial plan for the near future.
That's great. What about predicting patients that are going to do poorly? Are we at a point, do you think, or do you think that your research will ultimately lead to a way to predict who will do well and who may not?
Yeah, we're getting closer. So to do that type of work, you need a lot of patients to look at. And I don't have the number yet with the blood work. But with the blood work, as we measure all of these molecules day by day by day, when we get enough patients, we then look at those that did well versus those that did not. And we do the proper statistical analysis to see which one of those molecules or which combination can predict that poor outcome. And that's what we call a biomarker. So what we could potentially do on day 1 or 2 in the intensive care unit when a patient comes in, measure these molecules. We know the 3 or 4 or 5 to look at. We know if they're elevated to a certain degree, there's a very high likelihood based on past cases that that patient will do poorly. Why is that important? It's important because it gives us the information to say we should be mobilizing all of our interventions rapidly. We should be maybe more aggressive in that particular group, or in some cases, if it appears that they are not going to have a good outcome, we need to be talking with the families about how aggressive they want us to be. So it is important information.
Yeah. Doug, do you think that you followed these patients along long enough that you can see when they're going to start doing well? when they've turned and their inflammatory response has perhaps started to win the battle?
Yeah. Yeah. So we certainly are doing that. We don't have the numbers yet. The unfortunate part about this disease is once you get in the intensive care unit, the death rate's very, very high. Again, we're not very good at this point in time predicting who's going to die. We can see it's not going well. We can see that there's no improvement. But with them dying at that rate, that's a certain amount of information, but it doesn't give us all the information we need to answer your question.
Right. Now there's been some literature about ventilation in these patients. Can you speak a little bit about that? Are there different ways to ventilate these patients in particular that is better than other diseases?
Yeah. So COVID-19, one of the hallmarks of this disease is that it attacks your lungs. Of course, your lungs are there for gas exchange. That's how you get oxygen into your body. That's how you blow off the byproduct of your metabolism, which is carbon dioxide. So you need your lungs to function well, and you need a certain amount of healthy tissue in your lungs to do that. Sooner or later, as your lungs are getting sicker with the disease, you need assistance to get you through that part. And that's where most commonly we would put an endotracheal tube down through the mouth into the airway, and we would ventilate the lungs on your behalf with sedation and to make sure you're comfortable, of course. And then you hope that with your treatments and your care, the process starts to go away that caused the problem. And then you can eventually, as the lungs are healing, get the tube out. So that's our common thinking. There's a couple problems with it though. When we take a breath in, we're doing it through negative pressure. Our muscles expand our chest and that pulls air in. When we ventilate somebody, we're pushing air in. And that has potential, if we're not extremely careful, to actually cause more lung damage on lung that's already susceptible. So what's happening with COVID-19 patients is they need help. They can't get enough oxygen into their bodies, and they're starting to tucker out as they're breathing hard. And so eventually they need some degree of support. What we've been finding is if you put an endotracheal tube down too early, the likelihood of them getting off the ventilator isn't very good. Probably a combination of the fact that they are a sick patient group moving forward very quickly with their sickness, but also the process of aggressively pushing air into the lungs may be exacerbating the damage that's already there. Mm-hmm. So what we're doing now is we're making every attempt not to intubate patients. So there are other modes of ventilation and support that we can provide, and we do those right until the very end. So for example, we have something called high flow nasal cannula. So these are nasal cannula that go in your nose, they fit very tightly, and they provide a really high flow of air and oxygen into your system. And with that high flow, it actually keeps your lungs stented open a little bit, and it's humidified. So it helps might help with secretions and keeping your lungs open and with gas exchange, and it may actually reduce your work of breathing. That would be the first step we do. The next step is with a mask to try CPAP or BiPAP, where we provide a certain degree of ventilation and support through a mask. But eventually, if somebody gets too tired, if somebody can't protect their airway, or if the gas exchange just isn't going well, then they still need an endotracheal tube. But unfortunately, there's a good chance they won't do well with it.
Now, can we talk a little bit about pediatrics? Of course, you're a pediatrician as well. How has the disease manifested in children?
Yeah, so this has been a really interesting part. When we started our work about 8 weeks ago, we were going off a study from London, UK, from the Imperial College, which was working off data in China and early data in Italy and Spain. Pardon me. And the suggestion there was that pediatrics were involved, not as much as adults, but still involved. So in fact, in our intensive care unit in London, we were preparing for between 50 and 56 critically ill children. We were doing all the pandemic planning. We were prepared. We were ready. We have not seen a single child in the ICU in London, which is great. And in fact, in Canada, right across Canada, country of 36, 37 million people, we've only had 2 children that have been reported to go into the intensive care unit with COVID-19, both of which, to my understanding, were discharged. So children seem to be getting off very, very lightly. We don't understand why.
Yeah, can you speculate as to a reason?
So we don't know, again, if there's something about being young gives you more resilience to the virus. We don't know if the immune response is more dampened in the children. We simply don't know what that difference is. But it's an important question, because if we can figure it out, there's a chance we might be able to emulate it in the more vulnerable populations.
Now,
what I can tell you is about 1 to 5%. The studies are telling us, and now we have data from New York, UK, other places as well. About 1 to 5% in these hotspots of children have been infected with COVID-19. So they are getting it. How are they presenting? They're presenting, about half of them are having either no symptoms or they're having very mild symptoms. And by mild symptoms, a dry cough, maybe a little fever, and it goes away relatively quickly. Then about another 30% will have moderate disease where they'll be a little bit worse off. They might need a brief hospital admission, although it's rare. And then there's, in those very rare cases, it's very, very low that children will wind up in the intensive care unit. And the number of deaths attributed to COVID-19 in the pediatric patients is exceedingly low. And it may be due to other unrecognized comorbidities. In other words, they may have a cardiac condition that wasn't recognized or something along those lines.
Now, the list of symptoms related to COVID seems to get longer daily. There's so many things attributable to COVID. And there's recent reports that children may manifest some of these different symptoms preferentially than others. Digestive issues, for instance, or even rashes have been reported. Do you think it's possible that children preferentially show different symptoms than adults?
Absolutely. So if we take a step back, you remember when all this started, we were looking for fever, cough, shortness of breath. That was COVID-19. Mm-hmm. And then it turned into, well, maybe there's some GI symptoms, some gastrointestinal symptoms like diarrhea and poor appetite. And then it evolved into, well, some people have troubles with smell and with taste. And then it moved into red eyes and conjunctivitis. So it is evolving, and we're seeing a bigger a more vast reporting of all these different symptoms. So it tells you that people are manifesting them differently. And now what we've realized in children, back to your original question, is that they're presenting very differently again. They're presenting with what we call a Kawasaki's like presentation. So there's something called Kawasaki's disease, which was initially described in Asian children. And it manifests with a whole bunch of symptoms. And we're seeing many of those symptoms in the kids that are testing positive for COVID-19. And as you said, it could be fever, it could be the GI symptoms, as you mentioned, so abdominal pain, some diarrhea, some vomiting. But then there's the rash and conjunctivitis and cracked lips and what we call a strawberry tongue, which is a tongue that's kind of swollen and red and spotted looking, just like a strawberry. So they are presenting very, very different. And you may have seen also these reports of COVID toes, yes, which is a very intriguing phenomena, where you've got these little red lesions on the toes of children, primarily children, that have had COVID-19. What they look like is what we would call septic emboli. In other words, when you get sick with an infection and your blood vessels get angry and inflamed, you're more likely to make little clots. Those little clots go to the peripheral blood vessels, like in the toes. So it's very intriguing. And there are some parallels where Kawasaki's disease is really a blood vessel disease. And now you've got COVID-19, which in children has Kawasaki's like symptoms, and you can also find these red toes, which look like these little blood clots. And then when I take the data from the adult side and work we've done here as well, and it's starting to appear that one of the major manifestations of COVID-19 is not only the immune system and the inflammatory response, but it's also a pro-coagulation, pro-thrombotic response, which means you're much more likely to clot. And that's because there's an interaction which is occurring between what's floating around in your blood and what's occurring at the blood vessel wall, which has been injured by the disease. And we have some great data on that from London.
I've seen some of that data regarding the increased incidence of clotting. Do you think that these patients need to prophylactically be on heparin or anticoagulation?
Yeah, yeah. So it's a great question, and yes, I do. But here's the problem: there's many ways of achieving anti of achieving a lower risk of clotting. You can use anticoagulation medications. You can use inhibitors of platelets, which are the cells that float around in your blood that clump together. So there's different methodologies on how to do this. The risk is, depending what you use, how aggressive you use it, you create a risk of bleeding in people, particularly in the older population where they have a higher risk of intracerebral bleeding or bleeding in the head, in the brain in particular. And then there's also the risk of bleeding in the stomach. So we have to be cautious how we approve this. Or how we approach this. What we're doing here in London is a set of experiments on all of the patients that we've seen. And we've identified what I think are going to be the major targets that we need to go after to stop that thrombosis potential. And I don't think it's so much related to what's going on in blood as it is to what's going on at the blood vessel wall.
Wow. Doug, this is all fantastic research, and I think clearly this is what we need to get to the bottom of a lot of these questions and to provide options for therapeutics. Is the research community finding that they are being well supported with research funding during this time?
So in general, yes. All of the governments at a provincial level, at national level, have stepped up with rapid funding processes. And we're involved in those where you write your grants very quickly. They're reviewing them quickly. But like everything else, they're being overwhelmed. So trying to find enough reviewers for the number of applications, trying to sort out which applications are going to lead to work that's going to influence patients immediately versus really great work at understanding the mechanisms, but may take 4 or 5 years instead of 1 year. There is good news here, I think. COVID-19 is a nasty disease and it needs to be treated with such caution. And but the good news is we're sorting things out, and I do anticipate for those, at least for those sicker patients, we will have rational therapeutics coming out very soon. In other words, when this all came on, we had no therapies for it. We still don't have any direct therapies for it. People just started throwing things at it. Well, let's try this because they're so sick. Now, as we start to understand what's going on in terms of the pathophysiology, now we can start doing it more rationally. We can say, hang on, that molecule is elevated. That molecule is involved in lung injury. Let's target that lung molecule with this therapy. We're at that point now. So I do think there are going to be some very effective therapies coming up. So when people start to be infected, what we're going to see is an antiviral, maybe a combination of antivirals, plus we're going to see something that affects the immune system as well, or perhaps some of these enzymes involved that are chewing up tissues. The ICU population will certainly be going after those blood clots.
Yeah, that's really exciting to hear, Doug. When we hear about vaccines versus therapeutics, clearly vaccines are a long ways away, at least 12 to 18 months is the best guess. If you had to guess, how far away are we from real targeted therapeutics which have some promise of working?
Well, let me give you an idea of what we're doing, and I think that will tell you how the process is working right now, how fast it's working, how well it's working. All the agencies and all the funding agencies, all the regulatory agencies right now recognize we need to do something quickly. People are dying. So to give you an idea, we've done some work recently, which is just being reviewed now for publication, where we've completely profiled this immune and inflammatory reaction. We've identified the targets that we think need to be inhibited to help patients. And we literally have reached out to the companies that make those targets. As of last week, we reached out to a company, came up with an agreement, have identified the drug, and we've already moved into an application for the actual clinical trial. And we've got a team of clinical trial people ready to roll. So all within less than a week, we've been able to accomplish that. Usually that would take months and months and months.
Wow.
And I anticipate the funding will come quickly and the trials will start quickly. So there'll be all these things that are going on with the vaccines, which are critically important, are also going to be happening with the therapeutics.
That's fantastic. Now, Doug, we're seeing provincially and nationally communities start to ease restrictions and start to open up. Are you happy with this? Do you think that this is the right move? Do you think we're at that point where we can do that?
Yeah, I don't have the answer, but I think the important point is nobody has the answer. Nobody knows. We've been through the first wave. The first wave seems to be dampening. We do have to do something for vulnerable populations. We have to do something for the economy. How do you balance all that out? I don't have the answers, and I think I'm quite confident when I say that the other government agencies and politicians, and nobody has the answer. So how do we do it? We do it cautiously, and we let the medicine and the science lead us. In other words, if we do start to open up, we do it cautiously with proper social distancing, masks, hand washing, and perhaps focusing on essential services first. And then if we see a problem, we pull back a little bit. If we don't see a problem, we move forward. We're going to see grumbling. We're going to see a little bit of up and down with the patient populations. But what we want to avoid is a steep rebound, or what we're referring to as the second wave. The fear in all of this is that it spreads rapidly again, it hits the vulnerable populations quickly, and the medical system is overrun again, or overrun, I should say. Luckily, we didn't face that, particularly here in London. We were well prepared. The people in the community listened to what the medical people were saying. We shut down appropriately. So we didn't have the problems that you saw in New York, in Italy, in Spain, and in the UK. But we have to approach this very cautiously.
Yeah. What about with kids? Do you think it's okay to start letting kids out and start to get back to school?
That's a very tough question, because we know kids are getting it. And even if they are not getting tremendously sick with it, they are going to be carriers and passing it on to their parents, to their relatives, to their grandparents. So again, it has to be done very carefully, cautiously. We have to watch what we're doing very closely. And then based on the medicine, the science, and the epidemiology, we pull back appropriately, or we move forward appropriately. And that's the only way we can go forward.
Well, that's fantastic, Doug. Thank you so much. Can you give people something? You've given a lot of, but can you give them a final note of hope to finish off here?
Yeah, I mean, like I said, I do think there's a lot of hope. Support your research that's going on at a national level. Support your research going on at a provincial level. Remember that without that research, we can't move forward, and that's what we need to do. We have great people in Canada doing it. We have some of the leading people in the world. We just need to support them and let them do what they do best. That's one aspect. But on a more of a global scale is don't lighten up too much. This is a severe disease. And as we move forward, think about all the principles that are there: social distancing, wearing a mask, washing your hands appropriately, and allow the medical and the scientific community to advise on how to move forward or pull back. It's going to be a dynamic process. Just be patient and do it together.
Thank you so much, Doug. This has been fantastic. And certainly you're one of those great researchers that's out there helping us all. So stay safe, and thanks again.
Thank you. Always a pleasure.
Have a good day.
You too. Bye-bye.